is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
Good morning, everybody. This is Dr. Zach Baker, Program Director with the R2P Sports Residency, and we have with us today a new cohort of sports residents. I've got Dr. Abbey Hammann here, who I have met before because she was a student here at R2P. And now she has returned as one of our two sports residents, along with Seth Hawks, who you'll be hearing from in another episode of our monthly research article reviews. And for those of you who haven't listened into one of these, our sports residents are required to do journal article reviews, which we leverage in our in-services here at R2P. So this is the fun part where I get to sit back and listen while Abbey, Seth, and our previous residents do all the hard work of finding a relevant article, filtering out the information, what is relevant, what is clinically applicable to us at R2P, and then we discuss it at our in-service. So, Abbey, welcome to the show. Good to have you on for the first time. And do you mind telling us what was the article that you chose? And for reference, the topic of this month was the knee.
So this month we're kind of diving into the knee. So I wanted to look further into an ACL repair compared to an ACL reconstruction. So the article we're going to talk about is altered knee loading following a primary ACL repair versus an ACL reconstruction.
Awesome. And I have been practicing for, 11 years now, and I've always been familiar with the two, ACL repair versus ACL reconstruction. Admittedly, I have never treated an ACL repair. I have seen hundreds of ACL reconstructions. I've never personally treated an ACL repair. I'm aware of a couple orthopedics that perform the repair, and I've talked with them just in regards to their rationale for doing a repair versus a reconstruction. But it is not something that I've encountered, despite just the high prevalence of knee injuries that we see. But it is something that was was more prevalent several decades back, kind of fell out of favor, and then is returning now again today. So I was excited when you picked this one because it's honestly one that I don't have much experience with. Do you mind talking a little bit about just kind of the background of the study, what they were hoping to achieve with it?
Yeah, so this year there was kind of renewed clinical interest in the ACL repair adding it back in as an ACL surgical management. In 1976, that's when that article came out that kind of dismissed repairs as being common practice for ACL management. But what the study did, it was a case control study. There were 30 participants. 15 participants were in each group. One group was ACL repairs. The other group was ACL reconstructions. All of these surgeries were completed by one surgeon. One of the biggest differences between the groups is that reconstruction group, the mean age was about 25 years, whereas in the repair group, the mean age was about 38, 39 years. And what they were looking at throughout this study was to compare peak extension moment of the involved side, the net knee joint power limb symmetry, and quadriceps limb symmetry. And when they were looking at that, they were doing that in a single leg squat test, and that was done approximately 12 weeks, 3 months out from the initial surgery date.
Awesome. And I think that's, to my understanding, with the ACL repair versus the reconstruction, the benefit of doing the repair is it's often looked at as a less invasive surgery. So if it's and not to say that it's minimally invasive, but there's less kind of changing of the terrain, if you will, in regards to what they need to do from a tunneling standpoint, from a harvesting standpoint. If you're taking an allograft versus an autograft, there's different things that you have to do with a reconstruction versus a repair. And I think logically with the repair, if it is something that's a little bit less invasive, ideally we have less secondary complications with regards to rehab standpoint. Maybe the symptom profile is a little bit less following. And then hopefully some of these things from a kinetic or a kinematic standpoint with regards to how we are loading the leg, how quickly we're achieving strength and regaining range of motion. If we are able to do that faster, or just to a greater degree, then outcomes can be maybe, if not comparable, but better with the repair. So I'm kind of curious to see what did they actually end up finding with this?
Yeah, and that was one of the things that they were kind of looking at, just to expand on that, is they kind of said one of the limitations of their study was that they wanted to dive more into like the arthrogenic muscle inhibition and kind of with quad lag and everything, kind of bringing all of that back into picture. Because as we know, that's one of the biggest things with reconstructions is sometimes getting that quad control to come back sooner rather than later. But as far as findings on this, their significance value was 0.05 for that p-value, but every single one of those categories, so again, the peak extension moment, the net knee joint power LSI, and the quadriceps LSI were all significant in favor of the repair. So the repair had all higher percentage values when compared to the reconstruction.
Was that surprising to you at all? Did you have any assumptions going into it?
I was a little bit surprised, but it was mainly just because I have never seen a repair as a student or in my first few months as a clinician, so I didn't feel like it was a super popular practice. One, for the article and kind of knowing that it wasn't a common practice anymore, but two, just because of things that I've heard about repairs and the rate of re-tears now in like present day. I was a little surprised with how big of a difference there were between the numbers 3 months post-op.
Now with this, did they go into any talk about following surgery? We know what they were measuring, and we know how they were gauging outcomes. Did they provide a standardized rehab protocol, or what were these individuals doing? Because I know they all had the surgery done by the same surgeon. Did they all go through the same rehab regimen, or did it reference if they were at least going to the same facility or have a relatively comparable experience there?
Yeah, it didn't reference if it was all done at one facility, but it did note that they all did similar, if not almost identical, post-op rehab. Now, everyone's a little bit different, so some things were a little bit modified. One of the biggest things that they pointed out was that none of the participants participated in pre-rehab. So they didn't see anyone pre-op, and that was like a big thing they were pointing out, because a lot of times they were noticing in previous research that with some prehab, individuals were able to have better outcomes post-op, so they wanted to make sure they standardized at least that portion a little bit more.
Well, when you get through the article, what were some takeaway conclusions that you left with? What were some maybe limitations or considerations for others who are reading this? And ultimately, like, what do we do with this information? How do we apply it? We're obviously not the ones doing the surgery. So how do you think this applies to us as PTs? And I know I just gave you like 17 questions to answer. Let's just start off. What were takeaways that you got from this?
One of my biggest takeaways was just to gain a little bit more insight to the repair and kind of, even though the study didn't look at a ton, to gain a better idea of how repairs or individuals with repairs fare after surgery compared to their reconstruction counterparts. So that was a big takeaway for me, to kind of take that in. And then also, in addition to that, looking at like a trend in like normal knee range of motion and just increasing strength post-op and just complications in general. A big thing with that was that the repair group had a smaller percentage of those complications when compared to the reconstruction. So I thought that was something that was interesting to see. And just for me, especially as a new clinician, to just kind of expand my insight. So if I do happen to have one of these individuals on my caseload, I have a better understanding and can kind of set certain expectations of where we would be at post-op with this group.
Yeah, I think from a big picture, it's just the appreciation of ACL repairs exist. And I think you get through school, we talk a lot about ACL reconstruction. That's obviously the higher prevalence surgery that we see. But ACL repairs are making a little bit of a comeback. So if you have a patient that is referencing one, not to be caught off guard by it, you now have yourself armed with a little bit of research and literature behind potential outcomes. And obviously, it's just one study. It just looked at 30 individuals. But it is showing that it is a viable option. This is me not speaking for the article, but just conversations that I have had with orthopedics that perform both repairs and reconstructions. I'm not aware, and this just could be my lack of knowledge or exposure, I'm not aware of any clinical prediction rules or guidelines that leads you to say the repair or the reconstruction is the better or the more appropriate option. But when I've talked with orthopedics who have performed both, these two orthopedics still, for individuals going back to high contact, high competitive, high impact sports, they were still leaning towards the reconstruction as opposed to the repair. Their rationale is just simply, I already get good results with it. I don't need to change anything at this moment. But for the individual that is maybe more of a recreational athlete, or they have an active lifestyle, but they're not doing anything competitive. So think about like your active adult, or even your sedentary individual who just has a fluke ACL injury. You know, they step off of a curb funny and they tear their ACL, but they don't have any large athletic aspirations to go back to. That repair may be a more viable option for them, especially if you get just as good outcomes with potentially a less involved or less invasive surgery. So I think just bringing top of mind that it's available, we're having some good outcomes with it, but obviously finding a individual to perform the surgery may be a little bit more challenging from a repair than a reconstruction standpoint. With this, were there any specific limitations that just people who are reading this or who are listening to this should be aware of?
Yeah, and just kind of bounce off of what you just said and kind of answer that is one of the limitations I feel is that the ages range from 12 to 60 years old, and in order to qualify as being a recreational or professional athlete, they only had to participate in 50 hours per year of sports participation. So that's not super high, so kind of bouncing off what you said in reference to your field athletes and those that are cutting and running. If they're in college and they're practicing well over those 50 hours per year. So I think that's a big thing to consider in this. And also in this study, it was very standardized who was being put in each group, because in the repair group, you had to have a proximal ACL disruption, and the classification had to be super specific of type 1, type 2 on that Sherman classification scale. So I feel like that's another big thing to consider with this group, this population. Also, you need to understand, I guess, for me, especially as a new clinician, is the potential effects of like altered knee loading mechanics. And that's kind of like my biggest takeaway from all of this is that even though they are both ACL management surgeries, the loading mechanics can be different based on the surgical intervention type.
Cool. And I think that conversation, you can go for a variety of different reasons. I really think that's where follow-up research and follow-up studies with this topic would go, because the title of the article is Altered Knee Loading Following ACL Repair versus Reconstruction. So just knowing, is there any altered knee loading, one versus the other? Is there a preferred method that gives you more ideal loading movement strategies? And then for the one that has less than ideal, how do we really dive into the numbers to figure out why are they loading in an altered strategy? Is it due to strength? And if it is due to strength, is that due to surgical trauma or surgical technique? Does it have to do with muscle inhibition, higher levels of symptom profile, inability to restore range of motion? So I think just knowing, is there a presence of an altered knee loading strategy? And then if there is, that's when we need to really dive into what metric can we track. Is it symptom level? Is it range of motion? Is it strength? Is it fear avoidance? What is limiting our ability to load in an optimal way? With this, whether it's ACL repair or reconstruction, I think a good thing to keep in mind for anybody who is working with this, our job remains the same. The protocol that we receive, the healing time frames, the constraints or the complications following each individual situation may be a little bit different, and that'll be communicated to you from the surgeon. But our job stays the same. We're still an impairment-based profession where we need to manage symptoms, we need to get range of motion back, we need to get strength back, and you can quantify strength in a variety of different ways, whether it's relative strength or absolute strength, looking at body weight strength, limb symmetry, the ability to load the joint externally. But those are all things that, regardless of the surgical procedure, we need to be trying to get back with either surgical procedure, and more importantly, measuring, testing, and tracking that progress. So, Abbey, thank you for your time and efforts on this article. This will be the first of many over the course of the year that we will be on here with. So, Abbey, thanks for joining us. For those listening, stay tuned for Seth Hawks, who is our other sports resident, who will be coming on to share his article.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.